Selamat pagi. Saya pakai batik nih, oke? Okay?
Selamat
Orang
pagi.
bule nggak ada batik, saya ada batik. Jadi saya pakai batik, saya bilang. Okay, on behalf of University of Utah and all the panelists and speakers, thank you for inviting us. It's a great honor to have here to contribute, and we're looking forward to for future collaborations. And I have my friends here. Dr. Glashbach will talk about other side of the TAVR, and also Mark Ibrahim talking about the imaging. But I'm going to start with aortic stenosis-induced heart failure and TAVR. So last year we were there. We talked about TAVR. We know about TAVR. You guys have noticed about TAVR, but we want to talk something a little bit different related to heart failure. Something that we might not pay attention, but it's a point of no return, because sometimes when we see somebody having a aortic stenosis, are they going to recover or they're not going to recover? So things that we like to see, it's still very nebulous, but we can talk something about it. This is my disclosure, very quick one. And this is, again, University of Utah at this time. This is like a few months ago in fall, so you can see how beautiful it is. So outline, I will talk about some background, severe aortic stenosis and TAVR growth. And not all TAVR patients survive or recover. We know that, we've seen that. And I'll talk about a couple of cases and why we talk about this. And then all these things that we predict mortality. What about recovery? Are we talking about myocardial recovery? Are we talking about patient recovery? And how do we measure that? What do we have now? What are we people doing? And what about the patient recovery? We're looking at the quality of life. So when actually is the right time? Because when we talk about recovery, there must be some factors that are affecting this. So severe aortic stenosis, we know it has a high mortality, and survival after onset of symptoms in patients with severe aortic stenosis is about 50% at 2 years if you don't treat them. And we see this famous graph by Dr. Ross and Brownwell in 1968, where they noticed that in patients who have 3 symptoms, angina, syncope, and failure, the survival very much affected. The problem is we don't know where that's going to happen. And we know that severe aortic stenosis has led to heart failure. And this is a very nice illustration of stage classification according to the extent of cardiac damage, from stage 0 up to stage 4, where the right ventricular damage is already happening. And this is, I call it as winning the lottery. The first TAVR was Ellen Crebier did in April 2002 in a 57-year-old patient. Now, 18 years later, TAVR is standard care for many of the procedures that we do today, including for low risk. Sorry. Currently, we are doing more than 80,000 cases annually in the US, and predicted by 2025, we're probably going to do more than 300,000 cases of TAVR per year. TAVR mortality is not zero. We know that, and we have to be very humble about that. We think this is it. We're going to treat everybody, but not. But TAVR still not zero mortality, even though it is getting better. If you look at 1 year adjusted mortality in 2007, is about 30%, and after 7 years later, it's a drop to 11%. So with newer technology, understanding of the technique, how to avoid complications, and the technology has improved the delivery system and the valve itself, it has dropped to a lower number, but it's not zero. So let me talk about a couple of cases before we talk about this. This is very contradicting. So case 1, we have 74 years old with CKD, severe AS, low EF, mean gradient is high, has dobutamine contractility by 20%, and underwent TAVR. Within 3 days, his EF improved to 50%. He felt better. He was discharged home. He said he felt a bit better. Then we have an 86 years old with CKD, severe AS, dilated cardiomyopathy, also 20% EF, but mean gradient of 15 millimeter mercury. Dobutamine echo, no improvement in stroke volume, but underwent a TAVR as well. We don't see any improvement in ejection fraction, but the patient said, I feel much, much better. He was discharged, went to rehab, but he died 8 months later. So the question is, why? Why is this happening? that why the TAVR mortality is not zero. Well, is it because the patient are too sick? There are too much comorbidities? Is it too late? We're just not quick enough to catch it. Remember that curve that I'll show you from Ross and Brownwall? Or there are procedure complications. There's some data to show that higher volume center has a better outcome. And this has led all to no recovery. So we take a look at it and led to death. Well, sometimes isn't it obvious? You know, I think this is in Jakarta, if not mistaken. This picture was taken. So, anyways. So in our last meeting, we said there's no point of no return. So is it all about just the right timing? So as I said, this is the famous graph, but where to catch that part is the difficult part. We just don't know when patients will go going on that slide. So why do we wait? Do we wait for symptoms or we just intervene? Very nice paper by Lancelotti to take a look at it, and then this basically give you some kind of guidelines, depends on the stage 0, stage 1 to 2, and what you do. In the stage C, asymptomatic, you wait for symptoms. And it also gives you some of the management options. So I wouldn't go details into that, but it's very nicely written in New England Journal of Medicine last year. So we know the pathophysiology. Severe aortic stenosis will lead to diastolic dysfunction, become symptomatic aortic stenosis. Then they have systolic dysfunction, low flow, low gradient, or paradoxical low flow, low gradient, then become end-stage heart failure and or with shock and death. But can we actually intervene with an AVR, leading to myocardial recovery? What is symptomatic aortic stenosis? What about over here? What about over here? So those are the things that we need to think about. This is possibly about the timing. And people have looked at many predictors of mortality in post-TAVR. And the latest trial from French Thyroid Registry, I just showed there's 2 interesting factors. Male and kidney function and atrial fibrillation also has significant contributions to mortality. But it's many things, it's not just one. So now we ask ourselves, do predictor of mortality foresee myocardial or patient recovery? Is really patient recovery really different from myocardial recovery? Then we're gonna ask ourselves, which one do you think is more important? So why some patients don't recover? Is it too late, as we talk about, the timing issues? Too sick, patient selection, complications, center experience? So we'll dive into that. So how do we select? This is very complicated. It's very hard. It's always individual. We see the patient and make a decision. Are we gonna do a 101 years old marathon runner? Or are we gonna do a recurrent heart failure hospitalizations patients, or patient with disabling stroke? So those are the things. Are we relying on STS score? Are we gonna do a TAVR score? Frailty, what about frailty? Do we use that to determine who should we select? What about using a new score? So frailty is just a number. People have done this. We have looked at frailty. And then geriatric syndrome has been taunted as one of the factors to look at. We use a lot of eyeball tests. Frailty test has been done, hand grip, 6-minute walk test, CATS index, and the valvular guidelines recommend the following parameters that we use. Not a frailty, if you can perform 5-minute walk, then less than 6 seconds, then we use this 5-minute walk to determine. But it's not perfect. We all seen, oh, it's not that perfect, but they didn't recover. Then TAVR score, people have done multiple TAVR score, but they're all not very specific. They all evaluate mortality, but none of them really account for patient-reported outcomes. So none predict, is this patient going to recover? Yeah, they're not going to die, but do they recover? None of them they do. So if we say, okay, recovered means equal to survive, but I don't think survive necessarily equal to recover. I think we all agree for that. Are we moving too fast down to the future? I don't know, just like the cartoon. So in the recovery post-TAVR, we have myocardial recovery. We also have patient recovery, and we can assess myocardial recovery by ejection fraction. We look at the dobutamine stress echo, left ventricle end-diastolic volume, global longitudinal strain by echo, and now we thinking about PV loops. But the patient recovery, we're relying pretty much on quality of life, and we have the Kansas City questionnaire for that. So we have seen all this variable, patient recovery with myocardial recovery. That's what we want. We love that. And then we have patient with a myocardial recovery, but no patient recovery. We get confused. Another one is patient recovery, but no myocardial recovery. And we also get confused why this happened. But we also sometimes see a patient without myocardial recovery and no patient recovery. That's the sad thing that we try to avoid. So before we go further, just this is the definition of myocardial recovery by National Heart and Lung and Blood Institute. A reversal of the pathological state of the myocardium with significant improvement in cardiac structure and function sufficient to achieve a sustained remission from recurrent heart failure events. So this is very important, to sustain remission from recurrent heart failure event. So what are the factors that determine myocardial recovery? We've seen that LV dimension and function. And we have seen this from a lesson from functional MR MitraClip trial. But because depends on the LV dimension, some patients just don't recover. The function, the mitral FR and the COAP trial, totally different because they have different anatomy and different subset of patients. Respond to inotropes, dobutamine challenge. Strain indices, people have looked at the global longitudinal strain. And what about the MRI? That's what my partner in crime, Dr. Mark Ibrahim, will talk more and to delineate about this MRI thing, which is a new thing. And scar burden, again, the MRI and question from a lesson from our AFib MRI and our future studies. What about the PV loop? We can talk something about that. So long-term cardiac recovery following TAVR is decrease in LVED dimensions and also increased EF after TAVR. It will have improvement in diastolic dysfunction and improvement in myocardial energetics. And we have seen this in several studies people have published, where there's improvement of LV performance if you have even with low EF. And the stroke volume also improve at 1 year. So increase left ventricular efficiency by doing a valve replacement. And TAVR is the least invasive treatment to treat aortic valve stenosis. Contractile reserve after TAVR and SAVR also have been shown that, you know, we see this with without cardiac reserve. Even though the lack of cardiac reserve did not impair recovery EF, survival of the transcatheter and survival AVR, cardiac reserve was associated with larger end diastolic volume decrease post AVR. So this back the questions: should we just not care and just do it? That's a big debate right now what to do. Again, and TOPAZ TAFI registry, EF improved following TAVR, but dobutamine stress echo failed to predict clinical outcomes of or EF changes over time. But 1/3 of patients with low flow, low gradient AS TAVR recipient died at 2 years follow-up with this association. So it's hard to predict. It's not easy, and it's an ongoing struggle for us. What about myocardial recovery with a strain? People have used echo to look at that, and it's been more superior than just the ejection fraction. We've seen that. What about patient recovery? Now, this is the most difficult part to get. We have done healthcare-related quality life after TAVR to take a look at this, but it's really, really hard. It's all aimed at quality of life because it really depends on the patient. Some patients just want to play golf, or they do. Some patients want to just go to a church or to a mosque. So it's really hard to do that, and it's not easy. But we have been using some kind of a quality metric measurement. But nevertheless, TAVR has been shown to improve quality of life, even though some patients remain debilitated. It's not perfect. So maybe timing is the key. Why wait? This is always the argument that we have when we see a patient with asymptomatic stage. You guys have seen all this graph, famous graph, and we have rescue patient in this level. We have encounter patient at this level, at that level, in this level. What about here? What about if we catch them before? We know they have severe aortic stenosis, and even though they're asymptomatic, maybe this is the time to actually fix it. Don't wait before they plunge into that really steep slope. And it's not cost safe as well, safe costs. So we are doing this. in our colleague from Korea doing an early surgery for or conservative care for asymptomatic aortic stenosis. In this randomized trial, early surgical aortic valve replacement resulted in a significantly lower risk of mortality or death from cardiovascular cause. So it showed that it's beneficial to do this, but this is surgical AVR. So are we talking about, are we doing it in a TAVR life? Yes, we are doing it. Early TAVR trial is currently ongoing, anticipated to be completed this year, but COVID might have slow it down a little bit, but we'll see. I think it's going to be interesting. So is there really a point of no return in TAVR? And I think there is. Just try to find that point. It's not easy, and it's an ongoing research. So clues to point of no return, it remains a very complex. We have used inotropic dependent cardiogenic shock as one of the indicators. If they don't respond, my gosh, should we even do this? And so really frail patients, should we even do it if they're even not able to move or really sick? And life expectancy of less than 1 year, and this has come into the guidelines. Again, it's not perfect. Well, the question is, we always argue among ourselves or discuss among ourselves that you'll never know until you try. So we always take a chance to do with this kind of patients because we want to help them. And severe AS, there is a point of no return. How to predict that is not easy, and it can lead to death, but maybe we can divert that, we can get into recovery and survival. So future direction, MRI strain and tissue characterizations, which is Mark Ibrahim is going to talk more. I would not discuss more details in that. So it gives superior strain assessment, give additional information through molecular data, ischemic infarct, total scar volume, and help distinguish ischemic versus valvular cardiomyopathy. We have done some PV loop in our TAVR, and it's published, and it's still ongoing. We are moving into the D3 now. We have the D1 classification where we get this number. But quickly, I would not go, and Dr. Welt might talk about that in the future. But the conclusion of that study that we did, pressure volume loop in TAVR patient are visible, structurally significant hemodynamics changes, cardiac function remains the same, blood pressure and volume decrease, but less work and stress by the heart after we replace the heart. But it'll be really interesting to see the data and then D3. So brainstorming, of course, Stavros always push us. He's still online here, and he said, like, what's next? What are you going to do? Well, maybe time for a recovery score. We take a look at LV diastole, diastology, EF, stroke volume, contractility reserve, global longitudinal strain, obstructive CAD, scar burden. There's so many factors that people have published that maybe can come out with a score. But we're still working on this, maybe potentially to predict. So that's my end of my talk, and then I'll thank all my team on my work on here. I cannot do this ourselves, and I'm very fortunate to be working with this team and our team. And then thank you again for inviting us. This is the picture that we had last year when we visited Surabaya, and looking forward to visit this again next year. Thank you.